Welcome back. Hope you're all teed up, so to speak. We just had an international panel. Probably the center of Earth when it comes to investment and testing of and development of artificial intelligence in healthcare is, of course, the United States. And so I'm really, really delighted to have introduced our next speaker, who is from the US and indeed from close to Silicon Valley. Dr. Andy Bindman. Andy he's a physician, but he's also the Chief Medical Officer and Executive Vice President of Kaiser Permanente in California, which, as many of you know, is a long-time friend of the NHS and also is very well respected across the globe and is one of the largest and most developed integrated healthcare systems in the United States. So Andy's going to tell us how KP is approaching this huge topic of artificial intelligence, and really looking forward to hearing what he has to say. Thank you, Andy.
Well, thank you so much for inviting me to be here with you today. It's truly an honor and a personal thrill to be back in London. I had the distinct pleasure of spending a year learning about the National Health Service as an Atlantic Fellow sponsored by the British Council back in 1999-2000. And the experience cemented my deep appreciation and admiration for the NHS. As Jennifer mentioned, I've been invited to talk about how Kaiser Permanente's work to create responsible AI governance and what that looks like in practice within our healthcare system. And I'm really glad that Jennifer mentioned as well that in the not so distant past, there was regular engagements between Kaiser Permanente and the National Health Service that enriched both systems. And I hope my participation here today might rekindle some of this activity going forward. For those who aren't familiar with Kaiser Permanente, I'll start just by explaining a little bit about who we are. We were founded in 1945, so we're celebrating our 80th birthday this year. We currently have about 12.6 million members in 8 states and the District of Columbia. And Kaiser Permanente actually recently announced an agreement to work jointly with an entity called Renown Health to operate a health plan and outpatient care delivery system that will bring Kaiser Permanente to the Northern Nevada area beginning in 2026. Understanding our unique model probably helps provide a little bit of context for how we're using AI within our integrated system. First of all, you should understand that members come to us, whether it's through employer-sponsored or individual coverage, or they may come to us through the Medicare program, which primarily serves the elderly, or the Medicaid program, which primarily serves the poor. Regardless of how they come, there's an upfront dues that is paid to access care and services that are coordinated across inpatient and outpatient settings, pharmacy, lab, and other ancillary services. The Kaiser Foundation Health Plan also then contracts through medical service agreements and provides a fixed budget to our physicians to be able to care for a defined population of members. So rather than those physicians, as is typical in most of the United States, charging fees for the services that they provide to charging fees to the health plan for the services they provide, they've been prepaid on a budgetary basis to provide the care over time. And so our integrated model essentially aligns incentives between the health plan and the medical groups so that everyone is incentivized to work together to keep the members healthy. And this offers considerable advantages in terms of adoption of new tools that will improve the care or experience for our members. Another advantage is that our health plan and physicians work together on the development and deployment of new tools This is so important to ensure that we complement existing workflows to help encourage adoption and create the regular feedback loops to see how the tools are working. And again, because there's a fixed amount of money to take care of a population without some of the constraints of fee-for-service revenue generation, it really does allow us to reconsider who, what, where, and how care is delivered. It allows us to think about how to maximize value with the flexibility of how our money is provided to us for the population. One example of how KP did this quite some time ago was the early adoption of IT systems. So KP was really a very early adopter, and many say sort of the home of where Epic cut its teeth, so to speak. And so KP really provided early leadership on the development of IT. Our IT system, as I say, is built on Epic, but Health Connect is the enterprise electronic health record system that we use. It integrates across all levels of service, including primary care, specialty care, inpatient, ambulatory, and our social health programs. So it connects more than 12 million members, 120,000 clinicians across Kaiser Permanente, providing technology and services that basically unify care, delivery, and operations. And as care has become more digital and patient needs more complex, Health Connect anchors and our connected ecosystem spanning pharmacy, virtual care, specialty applications, and more to deliver the right care at the right time, personalized to each member and clinician. Health Connect has the capacity to leverage automation and AI-driven tools to improve care. Some of the most promising new areas for investment to achieve greater value for our members are digital health, remote care monitoring, precision medicine, and now, of course, AI. So what is Kaiser Permanente's evolving AI strategy? I'll try to go over some of this with you. There are sort of four primary areas that I want to talk about with you that I'll expand upon in the remaining time of my comments. First of all, like many of the speakers who've come before me, we want to talk about a responsible way of implementing AI. Second, what is our governance framework for keeping pace with innovation while minimizing the risks that come with it? Third, our proactive approach to informing regulatory frameworks and clinical advancements. And finally, our efforts to try to build a workforce for the future using AI. So we're very fond of acronyms at KP, as you probably are here as well. So we'd like to talk about our principles related to a responsible AI built around the PROTECT principles. And these really serve as the foundation for evaluating and deploying AI tools. So what does PROTECT stand for? Well, the P is for privacy protecting. We prioritize our members' and patients' privacy, ensuring that it is safeguarded and in accordance with the laws and regulations in the United States. The R stands for reliable, that we develop and use AI tools that are consistently stable and secure. The O stands for outcome driven. We leverage AI to achieve results that align with our mission of providing high quality and affordable care. T, transparent. We ensure that patients are informed and give their consent to the use of AI when it's appropriate for their care. E, equitable. We harness AI to promote health equity, making sure our AI systems contribute to reducing disparities. C, customer focused. We focus on addressing the needs and outcomes that matter most to our members, employees, and clinicians. And then the final T, trustworthy. We build trust by employing safe, effective AI tools and continuously monitoring their performance. Again, many of these themes I think were reflected very well in some of our previous speakers. These principles that we have adopted at KP have been informed by engagements that we've had with thought leaders and policymakers, and we also have used them to inform our engagements with them. We are actively engaged in several key national efforts aimed at furthering responsible AI use across the United States. And we do this in several ways. For example, I've had the privilege of serving on the steering committee to help create an AI code of conduct in collaboration with the National Academy of Medicine. And this has provided a guiding framework to help ensure that healthcare AI tools perform both accurately, safely, reliably, and ethically. Another way that we try to engage in the community around this work is by studying and publishing on what we are learning as we are implementing AI. So Kaiser Permanente is sharing our processes and learnings from AI testing on various use cases, and they've been published in places like New England Journal of Medicine AI and New England Journal of Medicine Catalyst. And I'll share a little bit more about some of this in some of my upcoming comments. And then finally, Kaiser Permanente has been a founding member of what's called CHAI, or the Coalition for Health AI, a collaborative that's been focused on providing guidelines for responsible use of AI in healthcare. Ultimately, at Kaiser Permanente, we believe that policymakers should work with healthcare leaders to develop national industry-specific standards to govern the use, development, and ethics of AI in healthcare. By working closely with healthcare leaders, policymakers can establish standards that are effective, useful, timely, and not overly prescriptive. This is important because, as I think others have touched on, standards that are too rigid can stifle innovation, which would limit the ability of patients and providers to experience the many benefits AI tools can help to deliver. At Kaiser Permanente, we believe that a responsible approach to AI puts people at the center of decision-making. We believe that a responsible approach prioritizes safety, equity, and health outcomes in the development, assessment, and deployment of AI-based tools. To that end, we have a vice president for AI and emerging technologies at Kaiser Permanente, and he reports to me as the chief medical officer overseeing quality and safety for our organization. We evaluate potential AI technologies, continuously monitoring their performance and adhering to established clinical standards and guidelines. In terms of our AI governance framework, we have set up 3 special groups called AI councils. And these include clinical and business leaders who assess potential generative AI use cases that meet our standards and follow our general approach to generative AI. These councils coordinate with each other to avoid duplication. They maintain a list of generative AI tools that we use, and they continually monitor for AI risks. At this point in our journey, KP has really seen great promise in how AI can help us solve some of the challenges we face in healthcare, particularly when these, of course, are deployed responsibly. And this is focused in our early days on helping clinical teams focus on patients with the most immediate needs, improving patient-clinician interactions, and reducing clinicians' administrative burden, which we think contributes to preventing burnout. We are pursuing a multi-pronged approach to adopting AI tools. On the left side, you can see what we refer to as embedded. We are leveraging AI capabilities that are embedded within products we already use as an organization. For example, we have broadly adopted Microsoft's Copilot, which is now, for example, used routinely to summarize virtual meetings, and Epic's augmented response technology, which supports our clinicians in doing things like drafting messages to their patients about lab results. In leveraging these tools at scale, we are able to rapidly adopt capabilities that are relatively low risk and that would take us significant amounts of time to develop on our own. We also have a small number of vendors that we work with that I'm referring to here as niche capabilities that provide us with value related to a single impact function. And this is where I would put things like our assisted clinical documentation tool powered by Abridge. I'm going to talk a little bit more about that in a moment. As a general rule, integrating niche vendor products into our workflow introduces much more complexity than leveraging tools that are embedded within products we already rely upon, such as our electronic health record. So a niche vendor product has to be substantially better than what is otherwise available to make us view it as worth the extra effort involved in adopting it. And then finally, we do get involved in developing some AI tools ourselves. When we identify a need that we do not see that is available from available products to fill that need. And in a moment, I'll discuss a couple of these as well, and particularly, for example, an advanced alert monitor tool to stratify hospital patients. So let me say a little bit. We've heard a lot today about assisted clinical documentation. And I want to talk to you a little bit about our assisted clinical documentation tool to give you both a sense of our experience with this AI tool, but also to try to help illustrate for you our approach to responsible AI implementation. So an assisted clinical documentation tool is now available to all doctors and other clinicians at KP. That is, we implemented it with everyone, and we did this over just a series of a few months. The tool, powered by ambient listening technology from Abridge, supports doctors and other clinicians with securely capturing clinical notes during an in-person visit with patients and helps them to remain focused, as has been talked about, on the patients rather than at the keyboard where they have to spend time documenting or doing other administrative tasks. The assisted clinical documentation tool uses artificial intelligence to securely summarize relevant medical information from spoken natural conversations. Before we use this tool with any patient, it requires patient consent, and doctors and clinicians review the clinical note before it's actually uploaded into the patient's medical record. If a member does not agree to use the tool, the doctor will simply document the appointment in the traditional manner. I'll say the number of our members who decline or do not provide consent is very low, but we still think this is a very important part of the process. Following what was initially first a very successful piloting of the project in one of our geographic areas in 2023, we did embark on a system-wide deployment of this technology among our physicians and advanced practitioners in partnership with the vendor that I mentioned, and this started in January of 2024. Around the same time, executive sponsorship, which included myself as the physician leader on the health plan side, as well as physician leaders in our medical groups, we engaged informaticists, safety officers, quality risk leaders, and evaluators to outline and develop a QA approach that would enable rapid cycle assessment of the technology's performance in parallel with a rapid implementation process. Our goal was to evaluate whether the technology supported accurate clinical documentation without introducing bias or systematic irregularities. Selected physicians users received training from expert teams before being provisioned for licenses to use the technology. Our QA activities complemented model evaluation activities conducted by the vendor themselves. So this point has been brought up by others, the importance kind of post-marketing monitoring and surveillance of the tool. And really what we were providing was a real-world assessment across a variety of different clinical contexts. And given the rapidly evolving nature of the model, we prioritized a flexible QA quality assurance strategy that crowdsourced data to enable rapid assessment at scale. We blended kind of a structured assessment using a physician documentation quality instrument with thematic analysis of qualitative feedback from all available channels and established tight feedback loops with users, operational leaders, and the vendor. This was fundamental to both our learning process and building trust, which has been alluded to as well with our providers and with our patients. Ultimately, we identified no systematic critical irregularities in the draft notes produced by the AI-assisted tool. Although users expressed dissatisfaction with some areas of the technology's performance, some of these reflected the organization's learning curve, and the vast majority of feedback was quite positive. And as I said, we subsequently published this quality assurance review, where we found that 47% of the draft notes that were rated during the first 10 weeks of deployment were given 5 stars on a 5-star basis, and an additional 31% were given 4 stars, reflecting a largely positive user reaction to the technology's performance. We also received extremely positive feedback from our patients regarding their doctor's use of it and their sense of their doctor spending more time looking at them, talking to them, rather than typing during the office visit. I mentioned as well that we have played the role of AI developer by leveraging our vast database of clinical interactions with our members. For example, we have developed an AI-enabled advanced alert monitor that helps us to rapidly to work with a rapid response team to predict when hospitalized patients are likely to decline and perhaps need higher levels of service, like an intensive care unit. And in a randomized study that we published in the New England Journal of Medicine, we were able to estimate that we were saving approximately 500 lives per year. And again, the research associated with this was both important in terms of proving the value of the tool, but played a fundamental role in helping to spread the tool to sites that were not involved in the original development. So it really helped to create the buy-in, because I will share that many of our clinicians, when they were first talked about having a tool like this, said, well, wait, I'm already doing monitoring of these patients on the ward. Do I really need this? And I think conducting a study of this type allowed people to see the evidence to support further implementation of the tool. Another area that we've been very intentional with regard to developing a new tool is in response to recognizing that historically, when new technologies are introduced, they tend to widen disparities. And so we've been really mindful of how we can use a tool like AI to try to address inequities in health outcomes. So we have developed an AI predictive modeling tool to help address social needs affecting our members, and so that we can try to identify those who have need for social supports like food security, housing stability, and other kinds of things, transportation, that may make it more likely for them to be adherent in keeping visits to the clinic and the like. So what have been our challenges as we've moved toward adoption of AI in healthcare? You know, we really are at a critical period where we need to strike this balance, don't we, between a pace of rapid innovation in AI and addressing the risk. And as new AI tools continue to proliferate across the healthcare ecosystem, there are several things that we're watching for. First of all, what we see in many cases is a lot of focus on how to use the AI rather than how to use the AI to solve a specified clinical or operational problem. There's just a tremendous amount of focus on the bells and whistles and sort of how exciting it all is in isolation, and not really thinking about how it has to fit with the workflow of what goes on in the system of care. And so I think in many cases, there's a failure to recognize that the hard part is not about the AI invention. It's about how to make the AI fit within the delivery system so that it achieves goals of what we have to further population health, to improve efficiency and affordability, and all the things that are critical to allow people to get the maximum value out of what healthcare can offer to them. Another thing that we're really mindful of is how the tools that are being developed, what is the data that they're being developed on? And is it, in fact, in some cases, mimicking some of the biases of care that has gone on? I'm going to share a brief anecdote. When we started using that ambient scribe tool that I mentioned to you earlier, one of the hallucinations that we saw was that physicians started seeing occasionally a note that would, something that would appear in the note that they had never said, which was, you know, patient has high blood pressure, return to clinic in 4 weeks. And they were thinking, so I never told the patient to return in 4 weeks. Where is that coming from? And as we reflected on it, we thought perhaps the tool underwent some of its initial development on a fee-for-service database, which would be more inclined toward churning the patient more frequently to return to the visit, as opposed to providing the highest value way of delivering the care. So we do think it's really important that we understand what the kinds of data are that these tools are being developed on, and to recognize the biases that can be inherent in those underlying data sets. So our point of view around AI tools is that we need to systematically review these tools and to look for potential bias, especially when they are being deployed related to clinical functions. And it's really important to address concerns about bias at each stage of an algorithm's life cycle. This involves ensuring that the data used to train the algorithm is representative of the patient population, validating the algorithms in local settings, and conducting ongoing monitoring and evaluating the impact of the tool on various populations. Transparency from AI developers regarding the development and testing of tools is also important to understand how the tools work and the results along the way. So what are the next steps that we see for KP's journey in AI? Well, as we look toward the future in this rapidly evolving area, we're focusing on some of the following priority areas. Number one, the backbone that people have talked about in terms of the data. We need to further clean up, curate, and unify enterprise data. Without it, we will remain stuck in a whole bunch of fragmented pilots, something that I've heard, again, talked about here today. The power of these tools comes from how the underlying data and its accuracy are organized in the first place. Second, we want to build central utilities with reusable solutions, so we're not reinventing the wheel for every pilot. And this includes something that I think has really been highlighted here today. If a lot of what we need to do collectively is the kind of post-marketing surveillance equivalent, looking how these tools work in the real-world setting, we need to develop rigorous ways that we're doing this in a consistent way over time and that meet really what we're trying to accomplish. And I think many organizations are trying to figure that out on their own at this point, and I think there's a lot of shared learning that could come from how to do this successfully. I tried to share a little today about how we did that with our AI Scribe tool, but I think there's more work that could go on to really develop the science around that. We want to leverage embedded AI in core platforms like I talked about, where adoption is natural and the return is high. We want to scale proven solutions and extend them further downstream. So, what we did with our AI Scribe tool was not to sort of say, let's have a pilot over here and see if we can get some people to do it. We took a very strong central action to make sure it was deployed not only among all of our clinicians, our advanced practitioners, but all clinicians now involved in our organization. And so we have really made that fundamental. And I'll tell you, one of the returns that we've gotten from that is clarity as we've gone out to hire more clinicians who have said part of why they want to work with us is knowing that these kinds of tools are available to support their work and practice. And finally, about point solutions, I'll say we're using them very selectively and only where they provide clear, high impact at the edges, and not and only when they provide clear, high impact at the edges and not the core. That's not our core approach. Finally, what we're starting to focus more on, and it's been talked about, is how we drive AI fluency across the workforce so that adoption and trust grows as people understand how these tools fit into their daily work. And I want to finish by just giving one example of this. Many of you may not know that Kaiser Permanente also has a medical school. This is relatively young. We've had only 2 graduating classes so far, but we are playing an increasing role in medical education. And our school is called the Bernard J. Tyson School of Medicine. It opened in July of 2020. And its mission is to provide students with a world-class medical education that ignites a passion for learning, a desire to serve, and an unwavering commitment to improve the health and well-being of patients and communities. Well, medical schools like ours are really trying to think about how does AI fit into this? Do we hide it from the students and then let them learn these things and then bring it out? Or do we have to make it an active part of their learning from the get-go? I think many schools are grappling with this kind of issue. We think it's really important to figure out how to introduce it early so that our students do learn how in fact, it is deployed. So as one example, we've been conducting certain kinds of grand round lectures where, for example, we took one of our finest diagnosticians and presented, a clinical mystery case of sorts. And we had that individual talk about the reasoning and the differential diagnosis. And then we had the AI chatbot, try to solve the case at the same time. And they went back and forth. And interestingly, they came up with a lot of the same differential diagnosis. In fact, in some ways, I'd say the AI chatbot went a little deeper even into the differential diagnosis in some ways. Ultimately, they both were quite successful at arriving at an answer. I think there was strong consensus in how we teach that still we need humans in the loop, that we still have these very powerful tools that can aid in differential diagnosis and can give us increasingly insights into the reasoning associated with them. So we see real power in these tools and ways of, in fact, enhancing and elevating the skills of our physicians going forward. But I think we have to continue to think about how we introduce this not only with our physicians, but with our nurses and all of our health professionals to build the trust and engagement with these incredible tools. So with that, I think I'll bring this to a close and say thank you for the opportunity to share about Kaiser Permanente's journey with AI.
Thank you. Thank you so much, Andy. I hope you found that as interesting as I did. It's always very rich to hear from KP. And Andy, we've just got 5 minutes, so we've got really time for 3 probably quick questions. But it's very rich, and you'll be around hopefully a bit later in the networking reception. So the first thing is the evaluation. It sounds like you do a lot in-house. Is there a massive team? You don't have much fat to cut in NHS, and we don't generally have evaluative teams in-house, but how much of it is in-house, and is it big?
It's not big. So I mentioned there's a vice president of AI who reports to me. He actually has just a handful of folks, but we leverage across our organization internally. And it was key. Part of this is not just saying, oh, there's a bunch of experts, they're going to go off and give us an answer and give it back. We really engaged physician leaders as well as health plan leaders so that in fact there was shared responsibility and commitment to what are the important questions and how do we surface this. I mean, so much of it, the evaluation was developing very simple tools to, you heard me describe, using a 5-star system, how good was the note, so we didn't create, hundreds of pages of evaluation. So we kept it simple from a process perspective. We, again, crowdsourced both qualitative information that the clinician could write after a note, something back to us equivalent of what you might do on a Google rating or something like that. So we really tried to leverage our Health Connect system as a way of bringing in some of the data and then added a small survey on top. So it's really quite a small group, but they were able to do it quickly. And because they're embedded so tightly with the clinicians, I think they got great cooperation.
So KP did very digitally mature, very mature clinical leadership. You've got a lot of places in the United States won't have anything like that system. You've got 12.5 million people. How do you see this developing? Are there other centres like Kaiser, maybe not so big, that you could link with and have a kind of federated system of learning so you don't have to do everything all at the same time?
I think that's brilliant. And that's exactly what we think would be very helpful. Learning laboratories where, rather than every system having to work it out for themselves. And like you say, we're much better off and we're much larger. We have additional resources. And so I worry about smaller places that are, rural areas or have a high number of individuals who have lower socioeconomic background and whether they're going to have the resource to do that. So I feel like there's a community obligation to bring the learning collaborative together and to share that. And that's, again, why we're doing it. We're trying to publish. Everyone locally will want to have some way that they can understand it's relevant for their patient population. I mean, this happens in research all the time, but I think this is an incredibly important time for a shared learning collaborative.
Thank you. And you talked a lot about clinical outcomes and engaging the docs and clinicians in evaluation, but how far does the return on investment really, I presume it features quite highly, and how do you didn't really mention too much about that unless I missed it.
Yeah.
And how does that conflict if the docs are really wanting a particular clinical outcome and that the ROI isn't very good?
Yeah, so that's a great question. So I think there's a lot to actually unpack related to some of that. First of all, the health plan was involved in sort of purchasing this on behalf of the clinicians. And so the clinicians were both excited about it from the pilot and were open to expanding it. But of course, there was also some voices that were coming through to say, like, wait a minute, if we adopt this and get more efficient, is that purely going to show up as now we have to see 2 extra patients or things like that? And so we had to build trust by working together that there was going to be shared benefit for all. That, yes, of course, if there's enormous efficiency gains, shouldn't we return that back to our membership in terms of more visits? But a big part of what was being returned also was the clinicians being able to go to sleep at night without having to continue to work on their notes when they went home and things like that. Now, in terms of additional tools in which the clinicians might say, like, hey, we really need this thing, again, that's why these councils exist that involve the clinicians, involve the plan, and that we set up ways that we're going to evaluate these things together and make quick decisions about, does this look really promising? What does, in fact, it work out in terms of both, ultimately achieving our goals related to creating greater value in terms of what we're trying to produce for our members. So I do think it's a partnership like we have in Kaiser Permanente and everything we do, in which the clinicians have enormous frontline experience to share with us, but we also don't want to have our AI strategy purely driven by physicians. There are so many things that were talked about in the earlier panel in which there's various kinds of administrative work, supply chain, so many things about being a healthcare system that go beyond, can this thing make a more brilliant diagnosis than the doctor may have made on his own? In some ways, I think these administrative tasks are just win-wins in so many ways for the organization because they pull out inefficiency and they actually allow everyone to work at a higher level because they don't have to have those tasks as part of what they do.
Thank you. And last question is about patients and your enrollees, in fact. You mentioned involving them in feeding into evaluations, but is there any other work that you've been doing to really embed trust? And has it been a heavy lift with the enrollees, or has it actually been quite a reasonable task?
Yeah, so one of the things that we're trying to do related to building trust is also, and I mentioned this, trying to be transparent, that we would, we have the consent process related to the use of the scribe. We are developing standardized language that goes into, so for example, one of the things that we're using right now that I mentioned is the augmented response tool that will say, gee, we'll draft a note on behalf of the physician that the physician then reviews before it's sent out. Well, at the bottom of that note, where, should it say, this note was drafted in part with the help of AI so that the patient can be aware of that and know that the tool is being used that way. So I thought it was interesting earlier. I think I heard one example from one of our panelists about just listing what tools are being used in an organization. We're trying to make it a little bit more specific to the individual patient, like, oh, in your case, we did that. Now, in some of the things, we've been trying to think a little bit about that, like, oh, if AI is embedded within an EKG reading tool, should we have the note added there? So we're trying to work through those cases, and in general, we're defaulting toward more transparency than less because we think this will build trust. But we're also trying to figure out how to do it that it doesn't just become an endless burden where the patient is like, okay, enough with the disclaimers, just give me the results.
Yes. Okay, that's marvelous. Thank you so much, Andy. I think that was a really, really rich session. Thank you.
Yeah.